Welcome all to the today's maternal medicine module. Today's session is on TOG article. The article which we are going to discuss is a peripartum cardiomyopathy. This article is important from the examination point of view. There are SBAs which have been asked on this particular topic, so concentrate well on this topic. Definition, it is actually idiopathic cardiomyopathy. It is generally seen in the second and third trimester, late second and third trimester of the pregnancy, up to the 6 months postpartum. This can happen. Feature is there is a left ventricular systolic dysfunction. Left ejection fraction is characteristically less than 45%. Remember this left on 2D echo, you will get left ventricular ejection fraction around less than 45%. There may be associated left ventricular dilatation and diagnosis by exclusion. So in the pathophysiology, you have to remember this model, that is a two-hit model. Okay, so this two-hit model is first hit is by the genetic susceptibility. These patients are genetically prone to develop this cardiomyopathy. Okay, so genetic susceptibility is the first hit, and second is because of the various things which are happening into the blood. So what is happening? In the pituitary, there is a secretion of the prolactin, and this 16 kDa prolactin fragment that is acting on the endothelium, and that causes the release of MRINF 146A, and this causes the endothelial dysfunction. Okay, so there is an endothelial dysfunction, and from the placenta there is SFLT1. Okay, and this reduces the VEGF levels. Okay, so vascular endothelial growth factor level are reduced, so that leads to the endothelial dysfunction and also leads to the cardiomyocyte apoptosis and death. So the question which has been asked, which hormone is proposed in the etiology of this peripartum cardiomyopathy? The answer is prolactin. Okay, so there is a two-hit model. The one hit is a genetic susceptibility, and second is the environment which is created because of the endothelial dysfunction from two sources, one from the pituitary causing increasing the prolactin levels, and this placenta secreting SLFT1 reducing the VEGF level, and this 16 kDa prolactin fragment and this reduced VEGF levels will act on the endothelium. They will reduce the endothelial function, and this release of mRNA 146A will lead to the cardiomyocyte apoptosis and death. Okay, so here the same thing is given in the TOG in this particular figure. Okay, so basic concept here is there is a genetic susceptibility and pregnancy related vascular insult. The first hit is because of the genetic susceptibility. There are mutations which have been noted like TTN, BAC3, etc. This predisposes the myocardium to the injury, and hit 2 is because of the vascular and the hormonal insult. In late pregnancy, there are increased prolactin levels that cleave to toxic 16 kDa fragment. There is increased SFLT1, the anti-angiogenic factor, and increased oxidative stress, decreased STAT3. Final pathway is endothelial dysfunction, anti-angiogenesis, that is decreased levels of VEGF, and cardiomyocyte apoptosis leading to the left ventricular systolic failure. That is what we call clinically as a PPCM. Okay, so this is what is the two-hit hypothesis. As it is an SBA, they may ask you some question on this. Okay, epidemiology and the risk factors. This is seen in patients aged more than 30 years, multiparity, multiple pregnancy, obesity, chronic hypertension. Preeclampsia is associated and Afro-African ethnicity. This is very commonly seen. Then clinical features, there will be dyspnea, orthopnea, PND, pedal edema, fatigue, palpitation, chest pain, etc. There will be frothy sputum. Red flags. What are the red flags? Persistent tachycardia, chest pain, orthopnea, and tachypnea. These are the red flags. So symptoms of heart failure will be there. That is dyspnea, orthopnea, PND, pedal edema, unexplained cough, particularly when lying down, or which produces frothy pink sputum, dizziness, palpitation, fatigue, chest pain, abdominal discomfort. Okay, so this is what is the presentation. Then what are the investigations? What we have to do is ECG. Any new or unexplained cardiac symptoms in pregnancy will evaluate by ECG. There may be findings non-specific such as sinus tachycardia or STT changes. It helps to exclude pulmonary embolism and acute ischemia. Then lab tests such as CRP or WBC levels will be increased. That is the non-specific inflammatory markers. Then hemoglobin level may be reduced. Associated anemia is common. Then this is important. That is BNP and anti-pro-BNP ratio. That is increase in levels of BNP more than 100 and anti-pro-BNP more than 300. That supports this diagnosis. Then troponin T is usually normal. It helps to exclude the myocardial infarction. Okay. So this is what is the investigations role. Okay. So general principle of investigation is that it is a diagnosis by exclusion. Rule out cardiac plus non-cardiac causes of heart failure, and early suspicion plus prompt workup will give the better outcome. So most important is that it is the diagnosis by exclusion. You need to rule out cardiac and non-cardiac causes of heart failure first. Okay. So ECG we are going to do, the findings are non-specific, then this, but the specific will be BNP and anti-pro-BNP levels. BNP more than 100, anti-pro-BNP more than 300. That will support heart failure. Okay. Troponin T will be normal because that we need to exclude the MI. So these are the investigations which we need to do. Then chest X-ray. Findings will be non-specific. It may show cardiomegaly, pulmonary edema, pleural effusion. There will be septal lines, alveolar shadowing, etc. Echocardiography is the most important thing. Typically, you will get left ventricular ejection fraction less than 45%. That is essential for the diagnosis. Left ventricular dysfunction you will see on 2D echo. There will be dilated left ventricle most of the time. Okay. So the poor prognosis is if you have the left ventricular ejection fraction less than 30%, and if there is a dilatation of the left ventricular, end-diastolic dilatation of the left ventricle more than 6 centimeters, that has got the poorest outcome. Okay. Right ventricular dysfunction present will be the worst outcome. Okay. So this 2D echo finding will also predict recovery, need for transplant, mechanical support, and mortality. Then cardiac MRI, what is the role? Accurate chamber volume and function you can come to know. Detailed intracardiac thrombus better than echo, and tissue characterization such as fibrosis, necrosis is possible with MRI. Limitation, this is not a first line, and avoid gadolinium in pregnancy unless it is essential. It is safe in breastfeeding. Then endomyocardial biopsy can be performed, but this is rarely used. Indication is diagnostic uncertainty and to exclude other cardiomyopathies. However, the diagnosis is mainly clinical, supported by investigations and the typical presentation of the patient. So ECG will show sinus tachycardia, non-specific STT changes, BNP and anti-pro-BNP is increased, heart failure marker, troponin is usually normal, chest X-ray will show cardiomegaly, pulmonary edema. Echo is most important, showing left ventricular ejection fraction less than 45%. There will be associated left ventricular dilatation most of the time. MRI will detect thrombus and fibrosis. Biopsy is rare. So prognostic factor. If you have left ventricular ejection fraction less than 30%, left ventricular end-diastolic dimension more than 6 centimeters, right ventricular dysfunction, poor prognosis. Better prognosis if LVEF is near normal, smaller left ventricular size, and no right ventricular involvement. What are the complications which are seen in PPCM? Arrhythmias, 20% of patients. Intracardiac thrombus, if the LVEF is less than 35%. Stroke, pulmonary embolism, cardiogenic shock. Okay. Then what is the differential diagnosis of this condition? You may have benign dyspnea of pregnancy. The clinical presentation will be gradual and mild shortness of breath. There is no cough, normal vitals, and on investigation, chest X-ray will be normal, 2D echo will be normal. There may be arrhythmia, presentation will be palpitations, acute heart failure, tachycardia, edema. ECG will show tachyarrhythmia, chest X-ray will show pulmonary edema, echo will show the global hypokinesis. Okay. Then next is amniotic fluid embolism. There will be sudden collapse, peripartum plus postpartum presentation. There may be associated DIC, increased D dimer levels, decreased fibrinogen, and thrombocytopenia. There can be asthma, will present with the V's, decreased air entry, and accessory muscles of respiration will be working. Then pulmonary function test, and patient will respond to the bronchodilator. Pre-existing IDC. Okay. Idiopathic dilated cardiomyopathy. Earlier onset may be seen before second trimester also, and there will be larger heart. Echo, dilated chambers, MRI and BNP levels will be supportive. HIV cardiomyopathy, generally the patient will be known case of HIV, often non-dilated ventricles, and HIV test will be positive. Valvular heart disease, there will be murmur, earlier onset traumatic history will be there, and echo will show valve lesion, chest X-ray, left atrial enlargement will be there, especially if there is a mitral stenosis. Then hypertensive heart disease, there will be severe hypertension, may or may not be associated with proteinuria. Echo will show left ventricular hypertrophy, and left ventricular ejection fraction will be reduced, which may be mild or it may be preserved also. Then IHD, patient will present with the chest pain and heart failure. Atypical presentation may be there. ECG will show ischemia. There will be increased troponin level. Echo and angio will also be findings will also be there. Then next is a pulmonary embolism. There will be sudden shortness of breath, pleuritic pain. There may be history of DVT also, and CTP and V/Q scan will be important in this case. So this flowchart is important. There is a shortness of breath towards the end of the pregnancy or postpartum period, and natriuretic peptides, that is BNP or anti-pro-BNP, and echocardiography you have to do. So natriuretic peptides such as BNP or anti-pro-BNP you will do, and echocardiography you will do. If there is a raised natriuretic peptides, that is BNP more than 100 picogram per ml, or anti-pro-BNP is more than 300 picogram per ml, and ejection fraction is less than 45 or equal to 45%, then involve cardiology, consider diagnosis as a PPCM and other cardiovascular differential diagnosis. If the normal natriuretic peptides BNP is less than 100 picogram per ml, or anti-pro-BNP is less than 300 picogram per ml, and ejection fraction is more than 45%, PPCM is unlikely. Okay, so here PPCM is unlikely if you have a EF, ejection fraction more than 45%, and these BNP levels, natriuretic peptide levels are less than these given values. Okay, so in this case, consider non-cardiovascular causes. Okay, so this is the table which you need to keep in mind. Now coming to the management. So if the patient is pregnant and stable, the drugs which can be used, diuretics, that will give symptomatic relief. The caution is that it will also decrease the placental perfusion. Beta blockers are safe. Metoprolol is a preferred. Then hydrazine plus nitrates, alternative to AC inhibitors. Low molecular weight heparin if anticoagulation is required. Then which are the drugs which are contraindicated? AC inhibitors, ARBs, MRA, warfarin. These are the drugs which are contraindicated. Postpartum, during the breastfeeding, AC inhibitors are safe. ARBs can be used. Beta blockers are safe. Low molecular weight heparin and warfarin can also be used. Then postpartum, if the patient is not breastfeeding, all drugs can be used. That is ACE, ARB, MRA, ARNI, then SGLT2 inhibitors, directly acting oral anticoagulants can also be used. If the patient is hemodynamically unstable, then ICU care is required. Oxygen, IV diuretics, vasodilators if the BP is stable. Then inotropes, prefer levosimendan. Okay, so this is also a drug which has been given in the TOG article. That is one of the inotropes. Urgent delivery if the patient is pregnant, and mechanical support is also indicated. Then bromocriptine, it is a dopamine agonist, decreases the prolactin level, and always give anticoagulation along with it. Dose is around 2.5 milligram OD. In severe cases, it may be 2.5 milligram BD and then shift to OD. Then obstetric management, delivery if the patient is stable, vaginal delivery is preferred. If the patient is unstable, urgent delivery by appropriate mode, and severe heart failure, then the multidisciplinary team discussion is required, and accordingly the decision will be made. Intrapartum care, continuous CTG, strict fluid balance, left lateral tilt, low dose epidural, and shorten second stage by using appropriate instruments. Third stage, oxytocin slow infusion is safe. Ergometrin is to be avoided. PGF2 alpha use very cautiously. Breastfeeding, for stable condition, breastfeeding is allowed for the stable condition. Look for the ejection fraction. If the ejection fraction is less than 45%, or if the patient is symptomatic, then breastfeeding needs to be avoided. Okay. Prognosis, recovery is seen in around 50 to 80% of cases, generally within 6 months, and mortality is around 10%. In subsequent pregnancy, if there is a persistent dysfunction, then the pregnancy is contraindicated. There is a 50% deterioration and a high mortality if there is a persistent dysfunction. If left ventricular function is recovered, then there are 20% chances of relapse. Next pregnancy is to be avoided if left ventricular ejection fraction is less than 25% and there is no recovery. What is the contraception? Preferred is IUCD, that is copper or LNG. Progesterone only methods can be used. COCPs are to be avoided. Barrier methods will have a high failure rate. Okay. So what is the take home message? Left ventricular ejection fraction less than 45% is diagnostic when you have such a presentation. Then postpartum presentation is the most common, around 78% of cases. Strong association with preeclampsia. Thrombus risk if LVF is less than 35%, you need to anticoagulate these patients. AC inhibitors are contraindicated in pregnancy but safe in the postpartum period. Vaginal delivery is preferred unless unstable. Bromocriptine plus anticoagulation can be used. Then BNP levels are increased, but troponin level is normal. That will favor PPCM or the myocardial infarction. So this investigation in differential is very important to differentiate from myocardial infarction. The left ventricular ejection fraction is less than 30%, plus left ventricular end diastolic dimension is more than 6 centimeters. That has got the poor prognosis. MRI is best for thrombus, but not a first-line investigation. ECG will show non-specific changes, but helps to exclude other differentials. Okay, so that finishes the talk article discussion on peripartum cardiomyopathy. We have few SBAs. Dr. Sinchana, can you read these SBAs?
Yes, sir. A 32-year-old multiparous woman presents 2 weeks postpartum with progressive breathlessness, orthopnea, and fatigue. She had an uncomplicated pregnancy. On examination, pulse is 110 BP, 100 by 60 mmHg, and there are bilateral basal crepitations. Echocardiography shows LVF of 40% with dilated left ventricle. What is most likely diagnosis? A. Pulmonary embolism. B. Dilated cardiomyopathy unrelated to pregnancy. C. Peripartum cardiomyopathy. D. Acute coronary syndrome. E. Myocarditis. The C. Peripartum
Yes.
cardiomyopathy.
Why it is peripartum cardiomyopathy?
Because the left ventricular ejection fraction is less than equal to 45% with dilated left ventricle.
And
And the
presentation
patient
is
is
in the
presenting in postpartum period with
yes, yes.
feverish.
Okay, so read all points. Okay, take out the in the scenario. Always remember you have to select the points which are favoring. Next.
A 28-year-old woman presents 1 month after delivery with symptoms of heart failure. Echocardiography is performed. Which of the following findings is required for diagnosis of peripartum cardiomyopathy? A. LV hypertrophy. B. LVF less than 45%. Cardiomegaly on chest X-ray. Elevated BMP. Presence of arrhythmia. B. LVF less than 45%.
Yes, that
Most
is one of the
accurate option.
diagnoses. But if they would have given both B plus D, that would have been the best option according to me. Okay.
Yes.
Next.
A 35-year-old woman is diagnosed with peripartum cardiomyopathy. You are discussing experimental therapies targeting the underlying mechanism. Which of the following best explains the role of prolactin in the pathogenesis? Increased prolactin causes fluid retention. B. Prolactin causes direct myocardial hypertrophy. A cleaved 16 kilodalton prolactin fragment causes endothelial damage. Prolactin increases cardiac output. Prolactin causes coronary vasospasm. It is C.
Yes, it is a cleaved 16 kDa prolactin. Okay, 16 kilodalton prolactin fragment that causes endothelial damage. Okay, and that leads to some apoptosis and all those things. Okay, next.
A 36-year-old woman presents with breathlessness 3 weeks postpartum. She is diagnosed with peripartum cardiomyopathy. Which of the following is the strongest associated risk factors? A. Primary gravida, maternal age less than 25, preeclampsia, hypothyroidism, low BMI. C. Preeclampsia.
Preeclampsia.
Correct, preeclampsia. Next.
A woman presents with suspected peripartum cardiomyopathy, which is the most important investigation to confirm the diagnosis. A. ECG, chest X-ray, echocardiography, BMP, troponin. It is echocardiography. C.
Echocardiography. Yeah. Dr. Bina, madam, you want to take few questions?
Yes, I'll try.
Yeah. This.
A 30-year-old woman at 34 weeks gestation presents with confirmed peripartum cardiomyopathy and symptoms of heart failure. Which of the following medication is contraindicated? Very difficult question.
T
She,
T
she is
AC.
34 weeks, no?
Hmm?
Yes,
Yes,
AC inhibitors are contraindicated. We have seen drugs which are
enalapril.
contraindicated in Alapil. AC inhibitors, ARBs, these are contraindicated drugs.
Yeah,
Okay. Yeah. Okay.
antenatal, these are
Yeah.
contraindicated, but
Please
postnatally
concentrate
we
on the
can.
drugs. Drugs, duration of contraception. Okay.
Yes, sir.
And please also go through the, I have taken the tables from the talk article only, but please have the, visual image of the talk article tables also. Yeah, next doctor, continue.
A woman diagnosed with peripartum cardiomyopathy delivers vaginally. She is hemodynamically stable postpartum. Which medication should now be introduced as first line? So now it should be B.
She's postpartum, so it
Enalapril.
is safe. No, enalapril postpartum, it is safe.
Yeah.
Okay,
Yes, sir. A
next.
29-year-old woman with peripartum cardiomyopathy has an echo showing LVEF of 30%. What is the most appropriate additional management? Aspirin, no anticoagulation required, prophylactic LMWH, therapeutic anticoagulation, and clopidogrel. So this is D, therapeutic anticoagulation.
T
And
prophylactic.
it should be
Sorry, sir.
prophylactic. No,
So how
she has
can
got
you
a very
differentiate
high risk for the,
prophylactic and therapeutic?
yeah, but she has got a high risk, so she will require prophylactic. They have given D therapy.
No,
I don't know why, but
prophylactic or therapeutic, how do you decide?
see, therapeutic will be if there is a presence of thrombus.
Okay.
This
So there
I
is
need
no
to
thrombus,
consult,
but she
and
has a
then
high
we
risk.
need to we will have to have discussion on this latter. Okay, next
Okay.
doctor.
A woman with severe peripartum cardiomyopathy is started on bromocriptine. What is the main rationale for its use? Its use is improves myocardial contractility directly, reduces preload, inhibits formation of toxic prolactin fragments. So C is the answer.
So answer is C. It inhibits the formation of toxic prolactin fragments. Next.
A patient is started on bromocriptine for peripartum cardiomyopathy. What additional treatment is mandatory? What additional?
Bromocriptine along with,
Beta blocker.
no,
Sir, I don't know.
it is anticoagulation. So this
Anticoagulation.
patient should be on
Anticoagulant. Okay.
anticoagulation.
Okay.
Yeah. Next.
A 34-year-old woman at 37 weeks with a stable peripartum cardiomyopathy is being planned for delivery. What is the most appropriate mode of delivery? Emergency cesarean section, elective C-section, vaginal delivery, instrumental delivery, DV delivery. So C is a vaginal delivery.
Yeah, actually, it will not be such a straightforward question. There will be some clinical scenario will be given, because here we just want to say that vaginal delivery is not contraindicated. Okay, it will depend upon the scenario basically.
Obstetric.
Yeah, obstetric indication. Next.
A pregnant woman with peripartum cardiomyopathy develops worsening pulmonary edema despite optimal medical treatment. What is the next best step? Continue conservative treatment, increase diuretics, plan early delivery, start antibiotic, observe. So, plan early delivery, see,
There is a worsening
or
pulmonary edema despite medical management. They have not given the duration of the pregnancy. So early
see,
delivery
plan
is to be
early
planned.
delivery.
Early plan.
Hmm.
Yes. Next.
A woman diagnosed with peripartum cardiomyopathy recovers with normalization of LVEF after 6 months. What is the most appropriate counseling regarding future pregnancy? No risk of recurrence, pregnancy is contraindicated, risk of recurrence exists and needs counseling, sterilization is mandatory, no follow-up required. The C, risk of recurrence
Yes, risk
exists
of
and needs
recurrence exists,
counseling.
and she needs counseling. Almost 20% there is a risk, increased risk of recurrence. Next.
Which of the following is associated with a poor prognosis in peripartum cardiomyopathy? So it is persistently reduced LVEF.
Yes. C. Persistently reduced LVF. Last question, doctor.
A 31-year-old woman presents 1 week postpartum with acute dyspnea and chest pain. She is tachycardic and hypoxic. Which diagnosis must be urgently excluded before diagnosing PPCM? So it is B, pulmonary embolism.
Yes, yes. See, when you read this, that is why I have given the table of differential. That table is going to be very, very important. They will give you 7-8 line scenario, and accordingly, you should be able to, click this differential. Okay. So if at all you want to label this as a PPCM, but you need to rule out pulmonary embolism because she's postpartum, presenting as acute dyspnea, chest pain,
Acute
etc., etc.
symptoms.
Okay.
Yes.
So the option. So that finishes our topic of peripartum cardiomyopathy. Thank you, doctor. We stop here.
Thank you, doctor.